welcome to this session from Hand Therapy Essentials, which is a series brought to you by the AO North America Hand Education Committee. My name is Chaitanya Mudgal, and I'm from the MCh in Boston. And I'm really excited to introduce tonight's moderators, Tom Hunt, who's the professor and chairman at Baylor, and Rebecca Neiduski, who's the dean of the School of Health Sciences at Elon University. Today's session is on the wrist, and Tom and Becky will introduce their faculty. But before we get to the session, I wanted to take this opportunity to thank Tom. Tom has been a wonderful colleague and a member of the AO North America Hand Education Committee, and he'll be finishing at the end of June. So this is, in a way, his swan song. And I must say, Tom, thank you for being such a wonderful colleague and doing such beautiful work on the committee. And people who are watching are in for a treat today. The other thing I would like to bring people up to speed on is that the AO North America Hand Education Committee is really pleased to announce that we will be having a trauma representative joining us on our committee. And the first representative will be Christina Bolton from the University of Arizona in Tucson. And we have also introduced the concept of partner nation, which will be for 1 year. And our first partner nation will be India. And Anil Bhatt from Manipal will be the representative. So with that being said, Tom, once again, thank you for everything you've done for us, and it's all yours.
It's very kind of you, Chai. Really appreciate that. It kind of sounds like I'm dying, but otherwise, it's great. Anyway, it's a pleasure to be one of the moderators along with Becky Neiduski, and our focus, as heard, is hand therapy essentials in regard to wrist injuries. Yeah, there we go. And we're fortunate to be joined by some great faculty today. You can see we have Paige Kurtz, we have Romina Estevides, we have Dr. Harry Hoyen, Gilberto Gonzalez, and Jeffrey Greenberg. So you are indeed in store for a treat. These are our disclosures for the various people, you can see. Also, you'll be able to access the recording of this session on the YouTube channel under AO Hand North America. And a link will be sent out within 24 hours or so, I believe. So this is just one of a series of hand therapy essentials that have been put on under the guidance of Dr. Mudgal and Becky Neiduski. The first, Hand Therapy 101, flexor tendon injuries, extensor tendon injuries, nerve compression and nerve injuries. And then today, wrist. And then to follow us will be the elbow on June 3rd. And then a very interesting international roundtable on June 10th that I think you should try and tune into. So it's been a great series. Hopefully you've had the chance to enjoy some of the previous talks, and if not, see them on the YouTube channel. So as we're presenting, please understand that your microphones have been muted and your videos turned off, but we want to have interaction. And the best way to do that for you is through the Q&A box. Please send questions. We'll answer those questions either through just direct typing on the screen, or in some cases, we'll bring them to the larger group and discuss them in that manner. So interaction is what we're hoping for. So please participate in that way. So our learning objectives are as follows. Increase your knowledge of the roles of that the hand therapist plays in recovery after surgical treatment of nerve injuries and compression neuropathies. I think let's change that to wrist injuries and ligamentous disorders. And really learn therapeutic techniques and modalities and develop treatment strategies today for wrist injuries. So with that, I'm going to stop sharing, and Becky, would you like to take over?
Absolutely. What I'm going to do now is invite Dr. Hoyen to get us started talking about distal radius and ulnar fractures. Dr. Hoyen, the floor is yours.
Okay, thank you. Okay, I've like to thank everybody. This is a wonderful opportunity Welcome from Cleveland, Ohio. It's a beautiful evening here. And whether it's evening, afternoon, morning, wherever you are throughout the world, I think this should be a very informative session. Our charge for Romy and myself are just to raise fractures, and we have a little bit for the ulna as well. No relevant financial relationships for this talk. And it's exciting for me because it allows us to explore the methods of soft tissue treatment after trauma. And, you know, what we accomplish in the operating room needs to be followed up with traditional, and I have on the third part here, alternative methods and therapies, and how some of these relate to the different surgery types. So I'm going to introduce a case, and then Romy's going to go over some traditional as well as alternative methods. And I thought we'd start with this one. It's a 66-year-old female. She had fallen, and it throws a little curveball into one of these, is that she's had a previous distal radius fracture on the same side, same upper extremity. And you can see here there's standard PA and lateral radiographs with dorsal displacement of the distal radius. The carpus follows along, as you can see on the right-hand image, and with the classic shortening and somewhat radial inclination. And you should challenge yourself to see, does the distal ulna move with the radius, or does it move separately? This is the post-reduction films that were obtained in the emergency department. And as you can see here, there's residual displacement of the radius and the ulna. And we won't necessarily belabor the point, but one of the things that Jerome is going to talk about is which parts of the wrist are involved, and how does she address each one of these parts of the wrist, from radial to ulnar, as well as from dorsal to volar. This is a fixation in this particular injury, given the fact that it was very distal, and I decided to show this one because it has some advantages as well as pitfalls, as we can discuss later on, and its appropriate restoration back to what was the individual's anatomy. And I also chose this one because it has supplemental K-wire fixation, and the K-wire is placed beneath the skin, and we can have a discussion. What do you do in the post-operative period with K-wires that are beneath the skin, or those that are outside of the skin? And as you can see here, the ulnar reduced reasonably well. There's evidence of a ulnar styloid non-union, and the ulnar head fracture, which is important on the ulnar column, remains reasonably stable. This is the 2-week radiograph, and I tried to pick one and identify one that had reasonable PA and lateral radiographs to give you an idea that at the 2-week point, this is relatively stable. This is one of the discussions we can have, is what's the appropriate time for follow-up, when to begin some of these modalities. I have just a quick video. It's about 35 seconds. This is her in the office supporting, and she kind of wants to fall into flexion after volar fixation. You can identify the stereostrips there. And we're going to try to have her rotate in pronation. You can see I try to exclude her face, and here she is trying to rotate into some supination. The last thing you'll see here is some finger motion, back up and down. And that's the sort of the prelude to Romy. And what I want you to think about is that we have the injury, the post-reduction, the operative intervention. Now we're here at about 10 days to 2 weeks. And you can certainly see this. This is, I would say, fair, but how do we go from fair to functional? Romy, if you could take over, that'd be great. I'm going to stop sharing.
All right, thank you very much. I guess I want to start with just talking about radius fractures. We often don't have all the information when the patient comes to us, and this is wonderful to see these x-rays and to see, but I just want everyone to remember that all fractures are not equal. Here's a case where the patient had already had a fracture before, and I would imagine a history of falls, but knowing all the information, how comminuted was the fracture, how many bones, was it close to the joint or more distal? What's the quality of the bone? All of that's very important information to get, if not the very first visit, but as quickly as possible, because it'll help change the course and how, and you can also, I think as therapists, we do a better job of explaining things to patients if we know a little bit more about what's going on. I also think that when you see that patient that first visit and you look at the amount of swelling, That's very, very important because somebody that comes in massively swollen will often have a longer recovery and more difficulty with motion. I also look at delay in surgery. In many cases, the patient may break their wrist, be reduced, be casted for 1 or 2 weeks, and then decide to have surgery. And so sometimes the surgery is not as quick as we'd like. So you have somebody that's already been immobilized for quite a bit of time. Oh, sorry, put my face on here too. Also, what's the age and the medical history of the patient? Do we have a patient that is older? Are they very worried about falls? Do they have to use any kind of device to walk? Because that can affect our recovery and how we want to treat them in the clinic. I also look at scar formation. If the patient has a history of scar, I think it's important to know if they've had a lot of scar tissue before, if they've had any other surgeries. And then certainly any other soft tissue injuries. Many of these patients come in and they have not only landed on the wrist, but have hit their elbow, may have injured their shoulder, and quite often their face as well. So just kind of knowing the whole big picture, I think helps me educate the patient and progress appropriately. And Dr. Hoyen, I don't know how often you actually share x-rays with your therapist. I often don't get to see the x-rays. Luckily these days, most patients come in with a picture that they took when they were in the doctor's office. So that does help me sometimes. But I think that's a nice thing to see, or even just to have that information sent out with the patient. So post-operative, I'm sorry, were you gonna?
Yeah, I think that's quite essential. We do the same thing is to have them have their own portable x-rays with them on their phone. And luckily enough, if you're in the same electronic medical record, I know the therapists do like to look at the radiographs and potentially review them. And this is the dialogue between therapy. And I know we discussed in some previous sessions is it's great to have the therapist with us in the office so that there's really a go-between, at least at that first visit.
Wonderful. As far as what I usually would recommend is some sort of removable device, obviously, so that the patient can start moving sooner. And that can go any number of directions. Sometimes we do just a thermoplastic wrist splint. In this patient, we would have had to been very careful about that radial pin to make sure that there's no pressure where the K-wire is. And maybe it would have been another option to put the thumb in as well to kind of protect that area. And sometimes if you have, although this was not as unstable, but if you have an unstable distal ulna or distal radioulnar joint, you may want to put the patient in some version of a Munster or sugar tongue orthosis to prevent rotation, at least in the first few weeks. And the nice thing with thermoplastic material is that sugar tongue or Munster sometimes can be converted to a wrist splint later on. And then how much do they wear the splint? Really, that's a good conversation between you and the therapist and the physician, the patient and the physician. I think that 100% depends, at least initially, on the fracture stability. So you can have a patient that goes anywhere from wearing the splint full time, only off for showers and for protected mobility, or you can have some patients that are coming out of their splint or cast or orthosis at 2 weeks, and they're doing some light things and then wearing it more when they're out in public. And I really think that depends 100% on the physician's preference in terms of the stability of the fracture. So this post-operative therapy, that's why I write 2 to 4 weeks, because depending on where and how unstable the fracture is, maybe we don't see them till 4 weeks. In this case, this patient was starting mobility much earlier, which is great. I would prefer to see somebody at 2 weeks, even if I can't move the wrist itself, just to get started on finger motion. I often tell my patients that their first priority is to get the fingers moving. We know as therapists how quickly, because of all the soft tissue mobilization that goes on during surgery, how quickly they get very, very swollen. There's scar tissue that forms between the skin and the tendons and the fixation. The fingers, the tendons can't glide well, and they lose finger motion very quickly. So I do a lot of focus on very deliberate finger motion. I always have patients that wiggle their fingers, and that drives me crazy because wiggling doesn't do much for you. I also do a lot of interossei stretching. If we think about our patients, they usually position themselves in MP flexion, IP extension, which makes the interossei very tight. And so you can often see a huge gain in motion, even during the course of therapy, if you stretch the interossei, as long as it's tolerated. And a lot of hook motion. We talk about making sure that the patient is focusing on flexing the IP joints. And certainly thumb motion as tolerated, as well as starting some wrist motion. So I will tell you what I see almost every time is tight interossei and poor gliding thumb. And also the index finger often has the most issues. The index and the thumb, I think primarily because their tendons run right along the line of the fracture. And so that becomes a problem. So once we start wrist motion, it's very important for the patient to work on motion one direction at a time. So I find patients that have very little success if they're going from flexion to extension. I much prefer they focus on just extension and back to neutral, or just flexion and back to neutral, and the same thing with rotation. That gives them a chance to really isolate the muscles. And we also talk a lot about patients making sure that they're moving the wrist. I would say that is probably a very critical thing for therapists, and not using the fingers to extend and the fingers to flex. Both of those are not great in the beginning. It doesn't isolate wrist motion, and it leads to bad habits, because it's very hard to hold on to something and extend your wrist if the only way you can extend your wrist is using your finger extensors. And then again, same thing for pronation, supination. I do a lot of focusing on one direction at a time, because that's that you get the most benefit from that. And along with this, I would say, and we'll talk about it a little bit more, but supination and pronation. Supination is very, very painful, and we never want to be aggressive with it. And we certainly, if we see any signs of instability, clicking, popping, that would definitely be slowed down or stopped. Okay. And the patient should be wearing their splint or orthosis between sessions. So Dr. Hoyen, do you ever tell them not to rotate at all?
This is a good point you have there, is that it's a bit dependent upon the stability. So in our particular instance, the ulnar head was reasonably stable, but if we try to do a good reconstruction of the sigmoid notch, pronation and supination is I think very permissible and encouraged. And supination is often harder to get than pronation, I think. When would you include, and we'll keep going because we want to keep on time here, but when would you include a dorsal support in addition to a volar support, sort of the clam concept, or not at all?
Me personally, I don't like those. I think they limit rotation even more than it is already. And unless if they have a job where they're in high traffic, where they could be injured or have a higher chance of falling, that is not my preference. I prefer just a volar. Or even if it's really stable, a prefabricated splint that has protection, both volar and dorsal. It limits them. It's very uncomfortable. It presses on the ulnar head. That's my personal choice.
Yeah, thank you. All right, go ahead.
Okay. I also want to talk a little bit about modalities here. I think a lot of patients think in their head that because they're swollen, they can only use ice. And it's a very big misnomer for patients. And so I have these patients that come in with this massively swollen, stiff hand, and they're icing every hour or 2 hours, and they're only getting worse. And so if I were to give one piece of advice, it's as soon as you're out beyond the immediate acute period, the heat makes a big difference in terms of the not only the swelling, you can visually see it sometimes decrease in therapy because it helps the circulation, but also in terms of the flexibility of the fingers. That being said, ice has many purposes, particularly as most patients by the end of the day, they're quite swollen, quite painful, and that's a good time to use ice as a pain modality and as a anti-inflammation modality. We also use other modalities, including e-stim, early on in this 2 or 4 week period if we need it for pain management. In addition to this early period, one of the things that I think is very helpful for patients is a gel sheet for their scar. Most patients have a lot of tenderness. particularly at the base of the thumb and at the distal end of the incision. That tends to be very, very uncomfortable. And when you combine that with a hard plastic orthosis, it can be very irritating to patients. And so I often will incorporate a gel sheet into the splint that they can wear, as well as elastic compression, whether it be a sleeve or some sort of a glove. That really helps with both the swelling, and I think it makes the patients feel good to have some sort of support. And I'm also a pretty regular user of flexible tape, like Kinesio tape or any of the other brands. Flexible tape, there's several different ways that you can use it for swelling management. And I find that patients really love the feeling of it. Sometimes for the patients that have a sensitive scar, it kind of takes away that constant irritation to the scar. And actually, what I tell patients a lot of times is, if you think about the tape on your hand, is that anytime you move, you're actually mobilizing the scar and you're mobilizing the tissue to help with the lymphatic treatment. So patients often feel much more secure and much more comfortable, and they will be more likely to move with the flexible tape. All right, a couple other things that are my favorites. We do a lot of rolling in the office. The nice thing with a rolling on a ball, and it doesn't have to be a ball. I have patients roll in peanut butter jars, anything that's big enough they can support their hand, is one, it takes gravity away so that they can move the wrist. And so just the motion, it's a very gradual motion. It's very comfortable. It doesn't require a lot of thinking on the patient, so they can just roll their wrist back and forth. So it gives them a chance to work on kind of that initial motion. That is one of my favorites. And I also do a lot of manipulation type activities, but with an extra emphasis on the functional aspect of palm down or pronation to grasp, supination to hold, pronation to grasp, supination to hold. And if you think this one activity of grasping foams uses the thumb, uses the fingers, uses pronation, supination, and wrist flexion extension. So it can be kind of an all-inclusive, and the patients can recreate it at home very easily with any number of materials. And it doesn't require, it's a very natural thing for them to do. Even with their non-dominant, it makes sense. It makes sense to pick up and hold something. I do also do a lot of wrist and bicep curls using no weight. And I tell patients that sometimes that's a preparation for when they will be using some weight. But I also think if you think of a bicep curl, that's a very large way to encourage supination. It's very functional. It's the way patients reach to their face. And so I do a lot of bicep curls primarily for supination, but the functional aspects are there. And also a lot of wrist curls, more just to teach people to isolate the ability to move the wrist without opening their fingers. Okay, so again, I see a lot of these substitution patterns, and we want to break that habit. We want patients to be able to grasp and move their wrist. Okay, and I can't not talk about shoulder here. It's super duper important that your patients are moving their shoulders. It's so common to have a shoulder problem after distal radius fracture, whether it's tendonitis, rotator cuff. So that should be part of every first session, whether it's with the physician or whether it's with therapists, just talking to patients about making sure they're elevating, making sure they're externally rotating, and assuming they could before, and internally rotating so that they prevent, because if you think about where most patients are sitting, they're in a compressive position, they're putting a lot of strain on the rotator cuff, and they're putting themselves at very high risk for a frozen shoulder. Okay. That being said, one of the things that I'm very, very careful with in terms of causing pain is rotation. I talk to patients, I want them moving, but I want it to be done relatively pain-free. Very important to be supported sometimes so they can do rotation with their other hand underneath. And again, this is a great time to stop if you're having problems and reach out to the physician. Sometimes you have to shut that down if the patient is really having symptoms. More ulnar-sided pain, if I start to see a lot of clicking or ECU subluxation, or more signs of distal radial ulnar joint instability, at this point we may need to stop and not do rotation, or go back to more immobilization. And I would think, Dr. Hoyen, you would think the same thing at this point. If things go wrong, the best thing to do is shut things down for a bit.
Yeah, probably a good idea. It's the old adage, just as we've heard on some of these, you have to do just the right amount, but not too much. And I think you're right on the money. Getting the fingers moving and the edema down. I like the idea you said, encouraging supination with bicep flexion and trying to get the hand to the face. I've always wondered how some of the tactics in establishing supination.
My favorite. It makes sense to people. All right, this patient, I brought him in just because I just happened to have this picture. This is not Dr. Hoyen's patient, but this patient came in, distal radius fracture with carpal tunnel release, open carpal tunnel release. And although you're looking at the hand right now and you're thinking this isn't too bad, the picture on the left is all the motion this patient has. So she is unable to close her fingers at all actively. Her wrist wants to position in flexion. And this is, if I see this coming in, if I haven't already communicated to the doctor, or if they haven't already communicated with me, this is a very close communication, because this patient has almost every sign of complex regional pain syndrome. She's got the swelling, the pain, vasomotor changes. She's got paresthesia that has worsened since surgery. And so treating this as quickly as possible, getting these patients in therapy, doing the correct medical intervention is critical to get a very good result for these patients. And I know this talk isn't long enough to go over all of this, but there are many ways to treat CRPS. And it starts with trying to get the patients moving as much as possible, getting the swelling under control, getting the pain under control. And that often includes teamwork between the physician and therapist. Okay, at 4 to 6 weeks, assuming things are going well, I often will send like a note to the doctor and say, can I strengthen, or when can I strengthen? How much can the patient lift? When can the patient add weight bearing? How much should the patient be wearing their splint or orthosis? And are there any other precautions? And the answers to all those questions 100% depend on the fracture stability. So you may get those answers at 4 weeks, depending on the x-ray, or you may get those answers closer to 6 weeks. And depending on if it's really a badly comminuted fracture, they may be closer to 8 weeks, where you can start initiating some of these things. And again, all along the whole process, if things are getting more painful, more swollen, you may need to slow down. You may need to take a break for a couple days from exercises, or if things are going well, you can progress, assuming that the fracture is stable enough to allow it. Okay. I always talk to my patients about weaning out of their orthosis or splint slowly. Many are just dying to get it off and they don't want to wear it anymore. But sometimes what you'll find is that they take it off, and then by that end of that night, they're extra swollen, extra painful. And I do like patients to wear something for sleeping, because they don't know if they roll over or if they whack their hand on something. So that's important. And then adding strengthening slowly when you start doing that, making sure that there's no increased pain or swelling. Okay. When I add more aggressive wrist stretching, assuming that is appropriate, I do always start stretching in neutral. And I think that's a little bit safer for patients. And then I add more. So I'll add neutral stretching, and then I'll add a little bit more composite stretching. So that's very important to do both together, as well as composite stretching, including the elbow. So those are the progressions. I start here, then I work with combined pronation, supination, and rotation, and then full stretch using the elbow. Okay. A couple things that you, as a therapist, don't want to add right away until you know that the fracture's healed is any kind of joint mobs. You want to make sure that there's good fracture fixation. Well, weight bearing should wait again until you know that there is appropriate, not fixations, fracture healing, forceful gripping for the same reason, and then any kind of other strengthening. One of my favorite little tools is these little flex bars, because they simulate a lot of real life. You know, we often do a combination of grip and twist. So I have patients do a lot of twisting, bending. So they'll do pronation, supination with that. And again, this is where often I'll start to see a lot of these patients complaining about shoulder pain. If you have your patient coming in and they are complaining not about their wrist, but their shoulder, that's often a worthwhile visit to the doctor to determine if there is a rotator cuff injury, if it's just impingement, and then to determine what the appropriate course of care is, because this will slow the patient down. They won't be able to use their arm if they're very painful. Okay, couple of other things. If the motion doesn't come back, there are some devices that are out commercially, and you can make your own custom orthosis as well to increase motion. Sometimes we're working on wrist flexion or extension, and you can also find similar type of devices for supination and pronation if that's what's lacking. If the patient is doing functionally well but is missing more motion, this is a great adjunct to have them switch to a home program and not be in the clinic, where they can do their own stretching at home. Okay. And I don't know, Dr. Hoyen, do you want to go back in and talk about this bridge plate? I don't know if we have time.
Yeah, I think maybe we could go back one slide if you could. In addition to these sort of things, what's the best exercise is for the fingers that get in this MP extended, slightly PIP flex position, right? You saw in both of those patients early on, we get this, but what happens in a month when it's post, wrist fracture? Radiographs are okay and all that, but they just have these stiff fingers. Give us a couple of pros.
So I do lots of different things, and it depends on the patient. Sometimes it's the most simple of things is to use Coban to pull the fingers down to stretch them. And so we can do that for 5 or 10 minutes. There are commercial gloves that do the same thing. Sometimes it's just a matter of making sure to teach the patient to start with MP flexion and then curl. I often will use their old wrist orthosis if I have, and I can add individual finger stretching devices to help. So I will often do something like a loop that flexes or stretches the MP joint. And then from there, when they've already kind of initiated that motion, then they can do active PIP flexion. So it forces them to go into a composite fist, but without allowing them to come back into the MP extension position.
Great. Given the fact that we have most of these situations where we're not including the forearm, the elbow and proximal forearm in mobilization, and we sit most of our lives in pronation, especially when we sleep on other things, other than the bicep and the face, when do you start rotation as long as the DREJ is stable? And give us sort of early, middle, and late tactics for those that have a difficulty. Is there a way to put the splint on that gets them in neutral, or a little supination at the beginning, or
yes? So I think in the very beginning, that's so painful that I think it'd be pushing your luck to put somebody in. But actually, the nice thing about these orthotics or orthosis, the wrist orthosis, is that you can, if depending on fairly early on, like let's say maybe the 3rd or 4th week, you can very easily use the actual straps and position the wrist in supination. So I teach patients, because we live in pronation, to put their splints in pronation because that's where they live. But for stretching purposes, if you just pull the strap the other way, you'll get a little bit of supination. And then I often also use long strips of neoprene, which is very cheap and commercially easy to find, or even a long strap. And I will wrap it around and kind of come around the elbow. So that's another way to work on supination. Patients can actually apply a heating pad and a little bit of weight in the supinated position to kind of do a stretch. I teach, but I tell them to eat popcorn, lots of repetition, trying to get using the tips of their fingers to their mouth. That's a lot of supination. And it's just, I think, making them aware that they have to stop and practice that. That's not something that always comes back naturally, and they can't cheat. Because we see a lot of that where they think they have supination, it's because their elbow is across their body. So those are my favorite tactics early on. And then if none of that works and it's stiff, other than joint mobs, some of these commercial devices work as well.
When would you start? Because this comes up a fair amount of time. Let's assuming the radiographs are stable. When do you use custom static progressive or the jazz splint, or a combination of dyna splints? Because we're often a little bit listening, very much so, listening to you all as well, as we get the reports back.
I think if the radiographs are stable at 6 to 8 weeks, if at 8 weeks they're not making progress, we're not seeing good change, I would start, and they're not as compliant with self-stretching, even as early as 8 weeks, I would consider ordering something that they could use. Unfortunately, a lot of patients prefer something that's on the more passive side, and those are a little bit more on the passive side. They can put it on and go about their business and do other things. And so I would have no problem starting at 8 weeks. Sometimes it just depends if I'm just not seeing progress, or if the patient is just not able to achieve what I can do in the clinic in terms of stretching on their own at home. One of these devices can help them do that fairly easily.
And maybe one final question for you, which I think, and we'll wrap this up here, is have you seen a difference given the progression from external fixator to dorsal plates, now to volar plates fixation, or angular stable fixation over your career? Is that what are the things that you've changed as the fixation methods have changed? With that question, then we'll have one final non-operative question.
Okay. I actually am thrilled with bridge plating, getting rid of X fixators. I thought they were awful. The patients hated them. They were constantly pulling over in supination. I think the concept of seeing something coming out of their skin created massive anxiety. And I can't tell you how many patients I had that had poor ability to close their hand because the distraction was excessive. Sometimes it was necessary, but it really slowed things down. Dorsal plates, it seemed like they were just here for it seemed like a short time. Volar plating, when that came on the scene, it was revolutionary. I mean, these were patients that would normally have been immobilized for so long, and we were getting them in the office at 2 weeks and starting, and some of them had 1 or 2 sessions of therapy, and they were able to kind of achieve their goals. And so I don't know that I've changed. I mean, I think I work with whatever's there. I would say that volar plating doesn't have the restrictions on the fingers that the dorsal stuff did, because I think that caused a lot more restriction because it tightened up the extensors. But I have a fair number of patients that have a really hard time gliding through because they are scarring down. So they both have their issues.
Yeah, that's great.
But I would want a volar plate for me.
Yeah, got it. So we're gonna we could keep going on for this, and so we have some other great talks. So thank you very much. And if you could stop sharing screen, then we'll go on to the next talk.
Thank you. And Romy, thanks for what a great tips. I mean, there's just so many things you shared with us. So thank you both also for the great conversation. Paige, I'm going to pass the baton to you to begin the discussion of carpal and perilunate instabilities.
Alrighty. Is everything coming up? All right, y'all can see that?
Sure
can.
can.
Okay, good. So I was kind of excited about this perilunate and carpal instability because I love those big whack high velocity injuries, but I also have a real personal love of the non-operative for this. So I'm going to stand on my soapbox for just a minute and talk to you about some of this stuff because I think this is actually a place where therapists have a way of presenting something that maybe the surgeons need. And some of you therapists, I know you're terrified by this stuff. And I really just at least want to give you some hope, perhaps. And I know surgeons and therapists, you get these patients, they have this vague history of something maybe happened once. It sort of hurts, but they can't localize it. Something's clunking once in a while, but I don't know when it does that. And everything you do on imaging and all the palpations, nothing is showing up as anything like you can find wrong. So either you write them off as crazy or you send them to therapy. Hopefully the therapists that are watching this will have the skills they need to deal with this after tonight, I hope. So this has become a real obsession for me. If you heard me talk on the 101, there's a lot of connections between proprioception and neuromuscular control in terms of scapholunate instability, in terms of the non-dissociative clunking risks, that catch-up clunk thing, ligament deficient risks. A lot of this has been Dr. Garcia Elias's work and also Dr. Hagert's work in regarding proprioceptions. So by using some of these things, we can actually decrease some of these crummy wrist symptom people, increasing proprioception, co-activation, and as Dr. Garcia Elias talks about, encouraging the friendly muscles and discouraging the unfriendly muscles. And I really love that because it's just such a simple way of categorizing them. If there are a therapist on here who has not read this article at least 100 times, please go out and get it. It was a game changer for me. Really changed the way I thought about everything. Again, Dr. Hager put this in the Journal of Hand Therapy a little over 10 years ago, and really nice kind of overview. She talks a lot about using co-activation, reflexive joint protection for stability for these kind of crummy wrists. And it's just a lot of these things are coming from people who have bad proprioception for whatever reason. So stabilizing the agonist, antagonist, all that good stuff. And we don't have time tonight for me to get through all of these, but these are two a little bit more protocol oriented articles that you can look up. I believe, I know for sure the bottom right one is open access everywhere. I don't think that European hand surgery is, but just to kind of get you a little bit more than I can get into tonight. But basically the concept of this is maybe your patient went and they were doing some, I don't know, gymnastics, they were out golfing, they did something different. They remember something kind of strange, maybe a pop or a clunk, or they were just doing something different. For whatever reason, they noticed that they started acting differently with their wrists. They start getting these compensatory movements, some adaptive motor strategies. You know, they know if it clunks when I do a certain thing, I won't do it. But they put a splint on. They just start using their wrist differently for a couple of weeks because they had a splint on that they found at Walmart. But the problem is that compensatory movement has messed up that brain-hand connection, is the way I think of it too. And that's now the new normal. And because of that, we have to unlearn that to get rid of some of these pains and problems. So a lot of the therapy is about retraining and undoing these habits, making the wrist smarter. And again, I like stupid terms because people understand them, especially my patients. I want to give them things that they can take home with them. So things that we'll use is a lot of bilateral to re-establish normal movement patterns, retraining self-mirroring, or even using mirror therapy. And all the basics things, and Remy already pretty much covered this, the patient education, orthoses, pain management techniques that we all pretty good at, I hope. So the goals of this re-education, there's a lot of words on this slide, sorry, but really that smooth and balanced wrist range of motion, that nice reciprocal flexion extension that a lot of times we just don't see that after some of these injuries and after any of the surgeries we're going to talk about tonight too. Using that dynamic muscular compression, again, co-activation, co-contraction. If you think about picking up something heavy, a laundry basket or something like that, your wrist locks down in order to stabilize it. That's co-activation. All the flexors and extensors are working together in order to stabilize that wrist. And so it's not doing what, you know, a wrist curl kind of movement. It's more the functional aspect of that wrist a lot of times is to stabilize. We can also use some of that when those ligaments are a little out of whack. Again, looking at the friendly versus unfriendly muscles that are potentially joint damaging. And then finally making that wrist, like I said, I like to make the wrist smarter. Unconscious activation, sensory motor activation, perturbation trainings, all kinds of big words, scary stuff, muscle activation. The way I give examples to my patients, if you're on a boat and it's rocking on the high seas, without thinking about it, to not fall over, you automatically tighten and loosen your knees one side than the other, or you tighten the muscles of your leg to not fall over. That's a lot of what proprioception and perturbation is about, getting people to quickly react to things. If I throw a ball across the room at somebody, they're gonna just put their hand up and catch it without really thinking about it. That's what we're trying to engage, to re-engage by making that a more normal movements and activities again. So for some specific applications, mostly these are from Dr. Garcia-Elias's articles. The friendly for an SL injury, not a full-blown SL tear, but an SL injury or instability, APL, ECRL, and FCR. And so by training these, stabilizing these, encouraging these muscles, we're going to hopefully make that SL a little less problematic. The ECU is our bad guy in this case, the unfriendly. DTM, which I thought it was in this one of these slides earlier, but I'll get into it later. But dart throwing motion is a natural plane of the wrist. Wrist extension with radial deviation, wrist flexion with ulnar deviation. So any of those kind of things. I use a lot of isometrics for these kind of retraining. I put people, Remy showed on the ball. I like the bilateral ball because we're self-mirroring in this case. And if you look at the movement, and I'll have some more slides later about this, you get a nice dart throwing motion. And again, it's a no-brainer. We really need to kind of break the weird habits and encourage the good movements again. And any kind of, you know, it's not, they're not trying to squash the ball, but they're loading into it, something of an isometric movement. With the LT, it's pretty much the opposite of the SL. So the friendly guy is the ECU and the unfriendly are the other guys. I like to do reverse dart throw is just really awkward to me, so I don't use that very often. I like to use, again, I mentioned the isometric type things. I have people just squish down on a foam block. And for the therapists who are not thinking this through all the time, you don't do it like as crazy as I am. ECU is really in pronation and in neutral is more of an ulnar deviator. So you want to keep that in mind. In this case, I'm engaging ECU by going into neutral. It's really not a true, because of the way it rotates with the forearm, not really a true wrist extensor until you get into supination. So you can engage it with ulnar deviation and pronation and ulnar deviation and neutral going into supination to hit the ECU for extension. And then I personally had, Dr. Garcia Elias is also is the personal observation. I had a bit of a catch-up clunk in my wrist for a long time. And I did try wearing the Boost orthosis, which is a great thing. It's just not functional. It's in the way. It's sitting there. It's obviously it's your kinesio tape to push up the pisiform into the triquetrum and pretty much fixes that catch-up clunk. But if we can create an internal boost by particularly the FCU is where I found that for me was the most useful thing. So training the FCU, engaging it, pushing, training it again, however you can, and the FCU again, and then the hypothenar muscles. Those are our friendly muscles for this guy. And I almost rarely clunk now, so I'm really happy for that personally. So I know it works. So again, the therapy protocol, so to speak, is not a protocol per se. Definitely can dive into those articles that I put out for your reference. But a lot of this is figuring out where the bad habits are, retraining, self-mirroring things wherever we can, bilateral, co-activation, co-contraction. Again, thinking in terms of a lot of stabilizing isometric type exercises. Again, engaging the friendly muscles, trying to knock out the unfriendly muscles for any specific incidents of whatever's going on. And then again, making that wrist a little bit of a smarter wrist is what we're looking at, trying to compensate for those compromised ligaments. And basically, you've already heard that so far. So I will stop sharing and hand it over to Dr. Greenberg to talk about the messy ones.
Hey, with all due respect, and I was planning on doing this, we are way behind time right now.
Gotcha.
We're way into the third session.
Okay.
And my topic, my case had really very little to do with what Paige just talked about. I was going to present a high energy case, and she covered the SIND and SID kind of cases. So let's just move on to the third session. Thank you.
All right, Dr. Gonzalez, that means you're up. So if you would go ahead and share your slides, please.
Right. Good. So good evening, everyone. Thank you for the opportunity to be here. We'll be talking about thumb CMC arthritis. No disclosures from my side. The learning objectives are going to be able to identify non-op versus op for the management of this problem and evaluate the different surgical treatments available. I'm going to go real quick on the biomechanics of the thumb CMC joint. This is a very complex joint because it includes a joint itself that it has different movements. Also has a very important volar big ligament, which is the main restrainer, but there are other ligaments as well as the inner metacarpal ligament, the posterior oblique, and the dorsal radial. The Eaton classification, which we use a lot for when we evaluating our X-rays, involves 4 stages. Stage 1 is the early stage. Stage 2, and when there is narrowing and some sclerosis, usually osteophytes less than 2 millimeters. Stage 3, there is more narrowing, and those osteophytes are bigger than 2 millimeters. And stage 4, when there is more involvement around, like the STT joint. Talking about the symptoms, physical examination and imaging, the symptoms are basically going to be pain. So this patient is going to be having pain with pinch and grasping activities. And the physical exam, I think that the key exam that we all of us do, it's the grind test, which is trying to emulate pain coming out of this joint. The basic X-rays that we obtain at the beginning are going to be an AP and lateral and the Roberts view in order to see the joint itself. Treatment, as any other thing in orthopedics, is going to be non-op at the beginning. We need to make a difference with these patients. Usually we get these patients in the clinic and they are elective patients. They come for pain. They decided to come to you because they want to be better. It's not the same when someone has a distal radius fracture, that needs to be fixed, and they didn't have any other option. So for this patient, most of the times that we mentioned before, unless that they've been extensively treated before, we offer non-op treatment, and with pain medications, thumb spica and bracing, and injections. We'll go a little bit in detail later on about the options for injections and what works and what doesn't work. When it comes to operative treatments, here I mentioned at least 6 of the options. Arthroscopy is usually for the early cases. First metacarpal osteotomy, it's something more of the past. I haven't done one in ages. Trapeziectomy and LRTI has been the gold standard for a very, very long time because it has very consistent results. CMC arthrodesis is for very selected group of patients. Basically, those are manual laborers, but it has to be done in with a pristine technique in order to work. CMC denervation, it's mostly for those patients that they come kind of like an early stage. They are not really sure about surgery. They really want to get rid of pain. And if it works in your hands, you might offer it to your patients. And some of them, they work knowing that that pain doesn't go away forever because this is a progressive process. And the CMC prosthetic arthroplasty that is being taken a lot of importance lately, and there are many companies out there, and it's good for you to know your system and what works on your hands. Complications, as any surgical procedure that we perform, it's going to be the first metacarpal subsidians. It collapses, especially when you are doing any interposition arthroplasty. And it is very, very important to consider if there is any associated MCP involvement, because if this patient has a hyperextension deformity and you don't treat it, even that you do your procedure very well and you expect to have good results, the patient is not gonna feel that way because the thumb itself as a unit is not gonna work the way it's supposed to work. So let's present this case of a 57-year-old female, right-hand dominant, past medical history of diabetes type 2. She's a smoker. Her past surgical history, it's on the other hand, on the left side. She had a previous surgery and she was not pleased with the results, but she was treated by someone else. She came with me because her right hand, which is the dominant side, it was giving her so much problems. Now she's retired, but she worked as a secretary typing a lot for over 30 years. And she presents with 6 months of pain at the base of the thumb of the right side, treated with her PCP with pain medications. Here we can see the X-rays, AP, lateral, and this kind of oblique view. We see how the narrowing of the joint space. We see how this funny shape of the trapezium, the widening of the base of the first metacarpal with the second metacarpal, and that classical osteophyte that we see. It's important to say that how bad the X-ray looks, it doesn't necessarily mean how the patient feels. Sometimes we get patients that the X-ray is not impressive at all, but the patient doesn't feel well. I mean, they can do anything with their thumbs. Other times we see impressive X-rays that there is so much collapse and you say, oh my gosh, how this patient can be function. And the patients are pretty much almost asymptomatic. Here I'm throwing some papers, some evidence out there. This is a systematic review of 33 articles, which consistently they mention that therapy reduces pain. When you choose what to inject, either the different type of steroids or other injectables like hyaluronate, they obtain similar results. And when you offer your patient the orthosis, the splint, it's going to reduce pain. Sometimes it doesn't really affect on the function of the strength when the splint is not on. That means that the patient needs to have the splint the whole time. This other one, here we have an RCT with 90 patients seeking for treatment. Most of the times, at least in my practice, patients come to clinic, you talk to them, you handle a brochure, especially if they are not sure about the procedure. They go home, they think about it, they come back and they decide. This work, I thought it was interesting because they are using an interactive web-based aid in order for the patient to make a decision. So they are recommending this one. On this paper, it's a questionnaire for patients. What do they expect for treatment? This is very important for us, especially as I mentioned before, if you are treating a patient with for an elective condition, what the patients expect in many ways. So the questionnaire was filled before treatment, 3, 6, and 12 months. And patients, they wanted to have pain reduction. As I mentioned before, pain is the main reason why patient comes in and visits and makes a trip to come and see you. Improve function 17% and return to ADL and 13%. No one mentioning cosmesis. Sometimes these thumbs, they have this Z deformity, and but still most of the times patients come to you because they want to get rid of pain. The expectations before surgery on those patients that you offer surgery, 92%, hoping that the pain disappear, and 59% on steroid injection. And now, which is important thing, look here how the ratio is inverted. The expectations 1 year after surgery, it's 77% on the surgical group and 24% on those patients treated initially with an injection. This in lieu of this presentation today, I think it's very important to see how a lot of the common hand conditions like carpal tunnel, trigger fingers, CMC osteoarthritis, the veins, ganglions, distal radius fracture. All these patients obtained from the TrueVen database. They have an incidence on the 90-day period. Utilization of PT or OT services, it was 14%. Based on this study, patients on the northeast of the country, they had a higher incidence than those in the south and the west. But what is important from this period of time, from 2007 to 2015, the use of therapy has increased over the time. Just a little bit of a history on of the surgical procedures that we offer. Trapeziectomy, it was the gold standard way before. There are reports from the late 40s where they started doing these procedures, and then we started doing interposition arthroplasties. LRTI came. There was a little bit of the debate at the beginning in order what to tendon or what to use to interpose. And I guess at the end of the day, we all agree that sometimes the radiographic height on the space between the joint, it doesn't really matter to see to evaluate how the patient feels. So surgical options nowadays, we have LRTI, we have excision arthroplasty. It really needs to see our patient's demands. And if it's a younger patient or if it's an older patient, hemiarthroplasty has been used. Some people, they use it a lot because they feel that you avoid the collapse of the metacarpal. You preserve the pinch and of the pinch strength, and so that's why they are using these hemiarthroplasty devices. Arthroscopic, as we mentioned before, for patients on early stages, and the mini thigh rub, which is using more and more. We still need more evidence in order to provide adequate recommendations. So going back to our patient, after 8 months under our treatment, under our care of occupational therapy, splinting, and 1 steroid injection, she didn't have a significant pain relief, and she decided to go for surgery. So here we have the X-ray. On this particular patient, I use a hemiarthroplasty. This device, what it does, you resect the base of the first metacarpal. You preserve most of the trapezium. And here we have in 3 different views. The most important that you need to see is that the implant is well placed, that there are no fractures on the base of your metacarpal. You can have some stress fractures at the beginning as part of the complications, and that the implant is in place. Patient evaluated at 1 week, 2 months, 6 months, and 1 year. And on her final evaluation, the patient recovered the strength of her thumb. This is patient a year later. Once again, we are trying to identify if there are any osteolysis, if there is any loosening. I mean, it's not the same when you are evaluating a total knee compared to on a joint that you don't have weight bearing. But still, you don't want to see a massive amount of osteolysis or a massive amount of loosening of the implant. I'm gonna stop here. And Paige, would you mind to share your screen? I'm gonna stop sharing mine right here. I think I think you're on.
Sorry. Let's run this. Okay, so there we go. So I have a little bit about pre-op and then also post-op. And honestly, I think a lot of the stuff that I'm doing pre-op is a lot of the same stuff I do post-op. So we can kind of cover a lot of it at once. Everything I do, if you didn't already hear this before, is about mobility versus stability. So thumbs have lots of movements, therefore they're inherently unstable. Again, we are seeing evidence that proprioception bad mechanics are a piece of the problem with CMC DJD as well. And even just loose, unstable thumbs. So we can also use this dynamic stability program for this kind of stuff. Again, some articles just to point out that we do know that just like the wrist, proprioception is a big role in CMC function and stability as well. Again, I've been living with a really crummy CMC, so I've tried a lot of these things on myself and they seem to work. More research recently has pointed to the first dorsal interosseous and opponens as a force couple that literally can reduce the joint subluxation of the CMC, which is pretty awesome for those of us who are trying to help people not have surgery. So think of those kinds of a force couple of sorts. There are friendly muscles, to use a term from the previous talk. This is an article that our Rebecca Neiduski was involved in, and this is more looking at like a personal training protocol, looking at biomechanics and how to teach them to the patient as far as dosing and things like that. So I just want to put that in there. But again, this is another one of those game-changing articles. If you're a therapist and you haven't read it, I would strongly encourage this, and I'll get through as much of it as I can, as fast as I can, but there's so much meat in this article that I've gone through it more and more times and keep looking for things. So find this one. If you're a member of ASHT, it is free to get any issue of the Journal of Hand Therapy. So basically, this is this approach in 5 steps, more or less. Opening up the web space. We've seen those collapsed thumbs. That's the biggest problem, that we really can't rebalance things until we get that loosened up. That adductor is our unfriendly muscle. Using joint mobilization, and not joint mobilization like stretching and moving the joint, but more mobilizing, making a happier joint. Teaching all those proprioception, friendly muscle things, training them up. Using the orthoses as needed to stabilize the CMC, to reduce pain, to increase function, to break some of those bad habits. And then finally using our classic joint protection, things that our therapy loves to do. So the first thing that she talks about, and this is Virginia O'Brien, I've conversed on a few times on some of these, and she one time said, well, you wouldn't train somebody to run a marathon if they had a knee contracture of 30 degrees. So I think opening up this adductor, it's leading into that collapse pattern, is one of the biggest things that we can teach our patients to do. I suspect that some of the therapy, the surgeries that just don't come out like we expected them to, maybe because those people had pre-existing just really horrendous adductor contractures, and we weren't able to get the normal thumb movements out of that thumb even after the surgery because of the adductor. So she has a whole bunch of different release things. There's a contract, relax, or just even I literally tell my patients, just get in there and kind of dig one web space into the other and just loosen it up, open up. She uses all kinds of funny things like chip clips as trigger point looseners, in fact. So the next part is the joint mobilization and distraction type of concept. And what we're doing with that is opening up the joint space is one example of one of the things I call it drop and drag. You just put your hand behind your back, let just the weight of one hand just gently loosen up that thumb. It's going to take some of the pressure off that grinding joint for a little bit, get some nutrition into the area, and reapproximate those joint surfaces where they can be pretty, highly involved. And again, there are probably about 5 or 6 ideas in this article for each one of these things, but due to time constraints, we will not go through all of these. Again, retraining the thenar area muscles is, again, think in terms of the friendly muscles. What do we want to do? Get them more stable, work on endurance, not strength as much. I am not a person who's going to use clothespins with pre or post-op CMC people. It's really going to be destabilizing to the joint. So re-educating, rebalancing those friendly muscles. I, again, like to use a lot of isometrics, holding the position with no movement, and then working through to isotonic movement without seeing any of those collapses. As soon as you try to get them to make an O and it's turning into a D, I make them stop. They're fatiguing the muscles. They're going to retrain bad patterns at that point. And I just love this picture. I've used this in another talk with therapists, because if you're a therapist, and it's hard to conceptualize, but you can see where that first DI is grabbing basically the base of that metacarpal and lifting it back up again. So it's not going to destabilize, with the addition of the opponent's pollicis being a bit of a lever to pull that thumb back in again too. So options on these sort of movements, the 8, you can certainly just use the first DI and just literally just AB, AD duct, adding in some manual resistance, or adding in a rubber band. I can even see when I see myself in this thing, my thumb, without really thinking about what I'm doing, when I resist that AD ductor, my thumb jumps into a nice stable position. And the C position is another one I like to train my patients to get there, get a C. We make it an O and a C. And that stabilizes. If you do that real hard and really isometrically contract that, you'll feel both the opponents and the first DI contract really nicely and strongly. And that's retraining a lot of things. Again, everything is opponents and holding that stable position. External stabilization program approaches mentioned in this program, anything from the basic orthosis, the hard plastic, to the soft ones, even kinesio tape, because there's a bit of a give to that we can use that also for a bit of a dynamic proprioception type of retraining. And then finally, the classic old school joint protection, energy conservation, wherever we can teach people new ways of doing things. Even the squishy co-band on a pen is nice. It enlarges the pen, but it also gives the person feedback if they're holding it too tightly. So there's a double, and again, proprioceptive component to it as well, and teaching people just to not terrorize these poor joints. So again, those are pretty much the principles. Again, take home messages, basically make them smarter thumbs, make them stabler thumbs, and consider the mobility and stability, basically. So I'm going to unshare again and hand it back over.
Hold on, I think that I clicked something that I was not supposed to click. Let's see, share screen. There we go. So thanks so much, Paige. I think that is very important what you just mentioned, because you guys, I'm sure that you agree with me, from all the universe of patients that we see out there, when we see them on the first initial visit, we send them to therapy, and a good amount of those patients, they get better. So from those patients that you initially see in clinic and they get managed therapy, they get better. It just a smaller amount of those patients that they ended up in surgery. I'm not gonna go through these papers because in lieu of the time, but I just want to mention that the main causes when you when this fails, this CMC arthroplasty surgery, it's because the collapse of the metacarpal onto the scaphoid, or because we miss or we undermine the importance of the MCP hyperextension that the patient had, or there was another associated arthritis like STT, or sometimes, as I mentioned before, sometimes the implant fails. When that happens, there are some salvage procedures that can be offered to the patient. But regardless what you ended up doing for your surgical technique, it is paramount that you have a good communication with your therapist. Where I practice, I'm lucky enough that most of my patients, they go into the same system. So the therapists, they have access to all my notes, and especially the x-rays, because as it was mentioned before, therapists, they do like to see the x-rays, and they judge us all many times. They say, they text me and say, I think that your plate or this looks different than it used to be, that we should do. So it is important to have good communication. When you operate your patients, it's important that whatever protocol that you choose, that it's how you guys feel that it works in terms of the time of mobilization, and or how you progress your patient from one splint into another. And patients' expectations are very important, because this is a procedure that once that you start, once you do the surgery, it's going to take a very long time for the patient to feel better. You know, to say, I'm convinced that going for the surgery was the right option. It takes at least 6 months for this patient to get a decent pinch grip, and sometimes it can take up to 1 year for the patient to completely feel better. And the take-home message, once again, it's important to counsel our patients that they know the limitations they are going to have at the beginning, the expectations, and the overall recovery time. And I don't know, you want to mention anything else, Paige?
It's up to y'all. I know we're tight on time, so I can throw this back up real quick. Let me see. Yeah, basically just the biggest thing, yeah, definitely educating patients that it takes time. There's really nothing else we can do but give them time. Again, it's all about mobility versus stability. So I use a lot of the things that are not as much, again, no clothespin pinching. Things that I like to have people do is holding, turning, like very functional activities, picking up coins, things like that, to re-educate the movements that are normalized patterns. Even just something as simple as having somebody hold a ball and tell them to show me that logo moving. It's very simple, but they're not, again, it's a no-brainer. I really like the no thinking things. So that's the kind of stuff that I'll get into. And honestly, my post-op is very similar to all the things you already saw pre-op. So.
Well, thank you so much. And then I guess the next group.
Yes, thank you very much, Paige and Dr. Gonzalez, for your great talks. Dr. Hunt, you have the last talk of the evening with Romy. So if you would go ahead and queue up your slides and share that last talk with us, that would be great.
Thank you very much, Becky, and great job, everybody, so far. Thank you for all your work. So I'm going to be fairly rapid in my section. I kind of cut it way back, and we're going to talk mainly about a case. But what we're going to discuss really are TFCC tears, and in specifics would be the unstable TFCC tears and how you handle that as a therapist. And again, I'm going to try and give the star of the show, Romy, a little bit more time here. So I progress along. Just a couple background slides. The triangular fiber cartilage and the complex really is important from the standpoint of anatomy and function. So it's obviously a collaboration of supporting structures. It is, in fact, a complex, and it functions to transmit load across the ulnar aspect of the joint. Approximately 20% of that load, of the load that's generated through grip in an ulna neutral patient. And importantly, it also functions to help stabilize the distal radial ulnar joint and to some degree the ulnocarpal joint. We won't talk about that in much detail today, but suffice to say that it's important for both stabilization and load transmission. And as we know, there are a series of different kinds of triangular fiber cartilage tears that are present. Andy Palmer came with a classification that's used quite commonly now. Class 1A, 1B, 1C, and 1D are all traumatic tears. And those that tend to cause more instability tend to be the 1B tears. You see there at the kind of the top right. And that's what we're going to be talking about today. But if you look at these class 1B tears, so tears that are on the periphery, either on the periphery and are associated with the capsule, or those that on the right, as you see, really involve the foveal fibers, so the true radial ulnar ligamentous attachments. And obviously, it's kind of a continuum with these tears from stable to unstable. So more capsular, partially stable injuries to those that are really unstable. With that as background, I just want to show one patient. So this is a 19-year-old right-hand dominant collegiate basketball player who is 18 months from injury to his right dominant wrist. He was originally diagnosed and treated with a styloid fracture, ulnar styloid fracture. And then that kind of continued and was thought he had secondary extensor carpal ulnaris tendonitis. So on examination, he had tenderness in the fovea, so kind of in the point of the wrist down here, and had a positive TFCC stress test. So when the wrist is positioned in an ulnar direction and then loaded, that caused discomfort, especially in comparison with the contralateral side. And importantly, this person had instability of his distal radial ulnar joint, and in his case, quite significant instability that had developed over this time. There was laxity and discomfort with stress of the distal radial ulnar joint. He had what we call a piano key sign. We don't really have time to go into the physical exam in detail, but suffice it to say that he was tender, he was unstable, and he needed something done. So these are his studies. You can see his MRI in the far left and then the center image. On the left, the coronal image. that shows a peripheral tear really at the fovea, right where that radial ulnar ligament attaches, and right at the place that he also had an ulnar styloid non-union. And over time, this active individual, this basketball player, has developed our early arthritic change at the distal radial ulnar joint that you can see on the axial image there in the center. And, now we've got instability, which is quite significant. We've got a reasonably high level athlete, and we've got the early degeneration that's occurring. And so for this reason, he was taken to surgery, and you can see just prior to doing anything, the prominence of his distal ulna in a neutral position. And this is what we found at the time of surgery. And this is looking at the dorsum, and the hand is to the top, elbow to the bottom. There on the left, the circle shows us kind of entering the styloid non-union on the ulnar aspect of the wrist. The extensor tendons are there to the left, to the radial side. And then as you look further, you look at the center image, the arrows are pointing to the extensor carpi ulnaris, and you can see the remnant in between those arrows that's subluxated and obviously ruptured. And here it is after we've kind of dissected it out on the far right. We've got the extensor retinaculum with the arrow to the left, and then the forceps are holding that remnant of dysfunctional extensor carpi ulnaris. So in his case, what we did, it was obviously an open reconstruction, so much more than your typical arthroscopic TFCC repair. And we did a bone tunnel type repair to really secure those dorsal and volar radial ulnar ligaments back to the fovea and get Sharpie's fibers to develop and really get those fibroosseous connections working again. So that was done. We also, because the extensor carpi ulnaris performs a very important function but was dysfunctional in this case, we took a palmaris longus graft from the volar side, brought it up and put an interpositional graft in place, and then used the extensor retinaculum, as you see there, kind of in the middle and then on the right as a means to keep the ECU tendon dorsal and in that way provide some secondary stability for the distal radial ulnar joint. So I think, and this is his final follow-up at 4 months. So with that, I'm going to go ahead and stop and turn it over to Romy.
Thank you. Can I ask you one quick question? What would you do if there was no palmaris? What would be the surgical intervention?
I think there are all sorts of different grafts you could utilize. When I'm in that situation, obviously you think, well, do you go to the other side or do you use a slip of flexor carpi radialis? And in him, that's probably what I would have done. I would have harvested perhaps half of his flexor carpi radialis.
Thank you.
Sure.
Okay, so I would say that this patient, this 18-year-old with our 19-year-old is probably one of the hardest cases you're going to see because you've got somebody who's very, very active and has a massive injury and has probably played through pain for a while. But most of these patients after surgery are immobilized in some fashion. Dr. Hunt likes to do an above elbow cast with a neutral wrist rotation for 6 weeks. And that makes perfect sense to me because this is a patient that would probably move if they were given the opportunity. Sometimes you could maybe do something a little bit more removable if need be, but you would have to have a very compliant patient. For these patients, it's super important again to make sure that they are moving their shoulder, protecting their rotator cuff, and moving their fingers. I do a lot of education about keeping a little bit of a pillow support up under the arm. That helps to take a little bit of the strain off of the rotator cuff because the cast has a weight keeping the arm supported, and then making sure to maintain whatever shoulder motion that you can do. As well as, this is the patient, if this patient was working in an office setting, how would they be able to type? What kind of modifications can we give them? I have often recommended keyboards that actually come up into a neutral position. I've had patients hold a pencil and use that to do their keyboarding, but you don't want to cause problems everywhere else in an effort to protect this if possible. And certainly not being able to rotate is very, very difficult in terms of function. I'm going to just run through this real quick, just to remind people again that ulnar variance, meaning the length of the ulna, changes relative to the radius with certain motions. So in pronation, automatically the variance increases and there's more pressure on the TFCC complex. And if you add grip with that, that's even more compression. So it actually kind of closes the space even more. So a lot of our functional activities, turning knobs, scrubbing, pouring anything, weight bearing, all put a tremendous amount of force on the TFCC. And then on top of that, you have the ECU that wants to sublux and supination, flexion and ulnar deviation. So in this situation, we're protecting a lot of different structures where neutral is your position where you want to be. And I will start day one talking about that with these patients. I will, they'll have to understand that they're going to live in neutral rotation for a long, long time to prevent re-injury or causing any damage to their repair. So again, we're starting 6 to 8 weeks post-surgery for most of these patients. And rare is the patient that can go straight from a cast to nothing. So a lot of these patients, sometimes we'll put them back in some sort of orthosis. This top picture is what I usually make as my version of a Munster. It is a dorsal Munster, but I find that it's a little bit more comfortable for the patients. I can blow out around the distal ulna so there's no pressure, or put a gel sheet in there. This is the classic Munster orthosis, and then the sugar tongue. Unfortunately, all of these, in an effort to keep rotation from happening, put pressure over the distal ulna, which is very, very painful for these people. So being aware of creating space there, not putting too much pressure there, using padding, using a blowout, whatever you need to do to keep that comfortable for the patient. And then under some circumstances, sometimes I'll do a prefabricated, but one of the longer ones, because that will, if cinched tight enough and has enough stays, will prevent rotation and give some support to the wrist. Pain management is critical for these patients. These patients come out extremely painful. They're extremely tender. The incision is tender. It's tender dorsally. It's tender ulnarly. They don't like things touching it. And so a lot of your typical pain modalities, heat, ice, I often will use ultrasound as well, depending, electrical stimulation, gel sheeting again to the scar, and that does protection as well, so they don't bump it suddenly. And then some sort of compression support. This is one of my patients that has just a basic ECU stabilization, but I make these very easy neoprene supports that the patient can put on and off, but it does a little bit of compression just to help protect and stabilize that distal ulna. And then certainly elastic sleeves are appropriate for swelling management. Okay, now I want to show you, this picture is definitely ball roll, but what you want to make sure you do when you do all of your wrist motion in this post-op period, you want to be in neutral. And so I talk to patients about neutral is kind of like the robot position, but if you take that same neutral and come straight down in front of you, you're still in neutral, if you want to think of it that way. You're not in pronation or supination, although it appears like you're in pronation. So the position where these patients need to rest is kind of with the elbow flexed and the arm in front of them versus out here, right? Out here you are in pronation, and here you're actually in neutral. So some of the exercises I'll do, and most of the exercise I'll either do straight up in neutral in front or out to the side if I want to do anything that allows some motion. So this is another ball roll exercise, and I like it only because, again, it takes the weight off of the wrist. You can do it in very limited range. The smaller the ball, the less you move, because you're going to bump your fingers. So you can kind of monitor it that way. But again, the patient is out to the side, almost in an abducted position. So that's why you see the patient, instead of facing forward, is patient is facing out to the side. We definitely got to get those fingers moving. And then again, if you're going to do flexion extension and pronation supination, it's all done starting from a neutral position and very limited range, very comfortable range. There is no force here. Everything here moves very, very slowly. because we're protecting structures, and in this case, structures that were unstable for a long period of time. And we also don't know, some people heal with a lot of tightness in scar tissue, some people don't. So you want to be a little bit more protective until you see how the patient does. Again, let's make sure we keep an eye on the shoulder, making sure the patient is working on external rotation, internal rotation, a lot of postural. Imagine now I'm putting these patients here, and they're going to have a lot of this weakness and kind of forward posture, which is disastrous for shoulders. Okay, at 8 to 10 weeks, we can progress to a little bit more active assisted range of motion, a little bit more stretching. Again, pain and symptoms guiding progression. And we don't want to go to the next phase of strengthening until we know that it's stable. And I personally prefer that the patient be 100% cleared by the physician, tested to make sure that that joint is stable the way it's supposed to be before we progress any further, or we may need to keep it slow for a little bit longer. However, sometimes these patients, they're so stiff, like the stability is excessive almost to some degree. And if you have a patient like that, even earlier on, you may want to communicate with the physician and say, hey, can we start moving a little bit more? I'm really worried that this patient is not moving at all. Can I start now doing a little bit of gentle stretch because they're not able to move normally? And certainly if you have any concerns about CRPS, those should be I guess communicate with the physician as quickly as possible so we can start treatment. And again, we never want to have anyone that has some new onset of pain or clicking. And I've just got some pictures of exercises in here. I'll tell you, okay, so I start everything in neutral, and I do a lot of isometrics to start with. That's a very safe way. Dr. Haggart actually recommended this little gizmo, and it's kind of nice. The patients have to stabilize the wrist to kind of get it to catch up. In addition, the flex bar staying in neutral. I also do a fair amount of taping and other gadgets. This is a wrist widget, which is a wrist support. I don't wear it the way I have my patients wear it a little differently, where I give them some ulnar support. I kind of flip it around so that it prevents ulnar deviation and also kind of helps support keeping that distal ulna down, not allowing it to dorsally move. And I also do a taping technique that is a rigid taping technique that actually helps, again, to keep the distal ulna in place to prevent that subluxation that we see. And then you want to progress to these end range things that are the really aggressive things like weight bearing and pronation, forceful wrist extension, and supination last. However, I am a big fan of never going there and really continuing to learn to focus on doing everything in neutral for these patients, both in jobs, at the gym. There's lots of ways that you can strengthen the shoulder, strengthen the trunk, and avoid full-on weight bearing. I think that once you have a wrist that looks like this, doing push-ups or something aggressive weight bearing is never a good idea. I do rotator cuff stabilization and strengthening very early on, and I keep it up. And those patients need to do that for the rest of their life, because a strong shoulder helps you have a strong wrist. If you have a weak scapula and weak rotator cuff, your wrist is going to take the brunt. And then long-term precautions, educate these patients on what is their forever no-nos. And I think that's it for me.
Just one comment from me. I thought that was great. Romy, I really like it. I especially like your strategy for return to activities and return to sport, and the taping and the maybe use of kinesio tape in a situation like that. I wish I would have thought of that at the time, to be honest with you. But I think that's always a struggle for these athletes is, they have these big problems and require fairly significant surgical procedures and lots of therapy. And then how do you transition them back to their life, especially these guys who are young and they're going there no matter what?
Yes.
How do you cushion the blow a little bit?
Yeah, so it's a lot of substitution, they have to just figure it out. And there's lots of trainers that understand. And I often will have them take pictures of their gym and show it to me, and I will show them what they can do and what they can't do and how to do it differently. Sometimes it works, sometimes they don't listen.
Kind of how it always goes, right, Romy?
Definitely.
Well, I just want to, we actually are ending right on time. I want to really lift up all of our awesome presenters tonight, Dr. Gonzalez, Dr. Hoyen, Dr. Hunt, Romy, and Paige. Thank you so much for all your wisdom, the great cases, the great information. I find these always so interesting, and I take home so many pearls of new ideas for treatment. And I know, or I hope that our attendees feel the same. So I'm going to go ahead and share my screen and wrap us up for the evening. A link to this recording will be sent to you through Zoom about 24 hours after the conclusion of the webinar to everyone who's registered. I also want to remind you that in case those links don't work, you can find us on the AO Hand North America YouTube channel. So go ahead and check that out. Also gives you an opportunity to watch any of the sessions you've missed. So we have 2 weeks left, and this has been a wonderful, really a great series. Our elbow session is next week, and we've got some really great elbow experts, Dr. Cassidy, Dr. Lawton, Dr. Ree, and Dr. Capo, as well as Alex St. Clair and Keely Elwood will be the primary therapists leading that session. And then to Dr. Hunt's point, we have a great international roundtable on June 10th, and just people coming from all over the world to really talk about what hand surgery and hand therapy looks like in underserved areas of the world. So we really hope that you'll join us for this really exciting international roundtable. So with that, I thank you very much for your time. I thank you for being here with us tonight, and especially to people who've been with us every week. We really appreciate your participation, and we hope you have a wonderful evening. Thank you so much.